So good afternoon, everybody. So my talk is consciously conservative YAG and iridoplasty, something that we routinely do and something that probably we're gonna be doing. So I'll just start off with this particular slide, which sums up that PACD is a dynamic disease. It's not something that is static. So this has been known right from the very beginning. Dr. Ravi Thomas has published a number of articles on this, and Ramanjit ma'am has summed it up in her synopsis. So the progression of PACS to PAC over 5 years is around 22%. PAC to PAC OHT is about 38.7%, and PAC OHT to PACG is around 30.7%. So there is a lot of progression. And this is true for cohorts all over the world. So it may be very less, like 1.6% progression noted in a Mongolian cohort by Yip et al., to as high as 35% seen in Eskimos. But there's no doubt that there is progression. Now, if you do a Google AI search or you search Grok, everybody's going to tell you that for a primary angle closure suspect, prophylactic LPI is definitely a treatment modality. And if you search all the journals, including this guest editorial by Krishnadas sir, it tells us that for high-risk PACS cases, you have to do a LPI. So there's no doubt that PI is the way to go forward. Now, Siddharth asked me to, just go into the basics of it. So definitely before a PI, you need to install pilocarpine, either 1 or 2 drops at 15-minute intervals. To prevent the IOP spike, you can use either systemic acetazolamide or some people prefer a topical brimonidine, 1 hour prior to and 1 drop immediately after a PI. If the cornea is edematous, you can use either topical glycerine, although I've never used it. IV mannitol, definitely yes, or oral hyperosmotic agents. Me personally, I always use a lens, and we've learned this from our PG days that they keep the lids open, they stabilize the eye, they focus the laser beam, provides magnification and act as a heat sink. So definitely there's this thing about magnification. And number 2 is power density is increased 2.5x. Therefore, you need a much lower energy to achieve adequate PI. Now, this is a question which everybody has on their minds as to what is the ideal location. Now, we know from very previously published studies and very old studies that, the completely covered LPIs have the least visual disturbances. However, after this particular study, which was published by the Arvind group in 559 South Indian patients, they stated that laser PI likely is safe with respect to visual dysphotopsias, regardless of the location, the size, and the amount of laser energy used. So probably, the best position of the location to do it is an ideal crypt where you'll be able to achieve a PI using the lowest amount of energy. So the location really does not matter. Now, once you do a PI, is it quantifiable? Can you see a quantifiable change? Now, it's very clear. I've quoted some of the latest studies. This one in 2022 using the Cassia 2, where the authors found that the LPI widens the anterior chamber angle in PACS, especially in the superior quadrant around the iridotomy hole. And not just that particular study, but this one using the DRI OCT Triton from Topcon. So there are these 2 basic things which happen. A, there is an improvement in all the angle parameters, the AOD, ARA, TISA, etc. And there is a change in the iris contour. So these are the 2 things which are very important, which you achieve after a PI. Now let's move on to this very important topic is it cost effective? So again, I've quoted 2 very recent studies published in 2024. One is by Fujita et al., the other by Rotham and Gibbons, both of which state that prophylactic LPI is cost effective across a spectrum of ages. So definitely it's a cost effective procedure. Now, is there a possibility of having a closed angle after LPI? And the answer to that is yes. It's not something new that we know. Dr. Ravi Thomas et al. In 1999, they said in their study, they found 23% of the eyes, they did not respond to an LPI. Even the ZAP, they stated that angle width of the treated eyes increased markedly after LPI, remained stable for 6 months, and then decrease significantly by 18 months. So again, like I said, PACD is a dynamic disease. So you're going to keep on following these patients. Not every one of them is going to react the same way. And this study from the Liwan eye study by Wong et al., they stated that some ITC, iridotrabecular contact, was found in 59% of the eyes, even with the patent PI. So progression with an LPI is going to occur because, like I said, it is a dynamic disease. And this study by Mani sir stated that in their study, it was a hospital-based study, 28% progressed to PAC. So these PACS cases, even after an LPI, 28% progressed. Now, 4 patients had passed adjacent to the PI site. So if you leave them out, 21% progressed. So that's a lot of progression. So who are these patients? Who are the patients who are likely to progress, and what should you look for? So older the age, higher the IOP at presentation, shallower the chamber angles, and narrower the peripheral angles, more likely these cases are going to progress. And if you're looking for parameters, the lens position, the cases having more anteriorly placed lenses, axial length, eyes with shorter axial length are likely to progress. Iris area, those with larger iris area, which means a smaller loss in area after dilatation. So the iris, imagine the iris as a sponge. So when a pupil dilates, the sponge should lose area and volume. If it does not, more likely these patients are going to go into a pupillary block. The lens thickness, that's also a predictive factor. So increased lens thickness and decreased anterior chamber angles. So if you want clinical parameters, those are the ones. If you want parameters like these which are quantifiable, these are the ones which you should look out for. Now, what did the ZAP trial say? So ZAP trial initially, it created a lot of stir because it stated that 44 LPIs need to be performed to prevent one single case of PAC. And 126 LPIs needed to be performed to prevent a single case of PACG. So is it an overkill? But if you look at the ZAP 14 years down the line, it still states that LPI significantly reduces the risk of PAC occurrence in PACS eyes by 2/3. So prophylactic LPI should be done primarily in high-risk population. That is, those patients who have a higher baseline IOP, those who have an IOP change after a dark room prone provocation test, those with shallow limbal anterior chamber depth and central anterior chamber depth. So high-risk cases definitely need to do a PI. But then there is an elephant in the room, and the elephant in the room is plateau iris. Because if you look at all these PACD cases, all studies all across the world, from India, from the US, from Singapore, 21 to 37% of these cases are actually plateau iris. So in plateau iris, PI alone is not going to be effective. And that is where iridoplasty becomes very, very important. So in iridoplasty, you're applying low power, long duration burns to the periphery of the iris. So it contracts the pigment epithelium, pulls the iris stroma away from the structures. So there's a mechanical widening of the angle. You can visualize the structures better and possibly a release of PAS. So like I said, a large spot size, low power, and a long duration. So 20 to 25 spots distributed over 360 degrees. Now, LPI is still indicated if a pupillary block is present. So this concept of LPI plus iridoplasty is not new. Look at this study way back from 1999 by Dr. Thomas. In their studies, 54 eyes, that's 23%, they did not respond to a PI. But then they went ahead and did a gonioplasty, and all responded to a gonioplasty. So again, it's not something new, maybe something which we missed the importance of a iridoplasty. So iridoplasty widens the angle. So this is a study which we had published in 2015, and at that point in time, I was doing a lot of iridoplasty, and studies down the line, they've also stated the same thing, that eyes with synovial angle closure and plateau iris who do not show an improvement in their chamber parameters after an iridotomy, a peripheral iridoplasty can be very, very effective. So the use case scenarios are A, an acute attack. So this was a study which was published from Singapore, where they had two groups. In an acute attack group, they did an iridoplasty and they found that the treatment strategies in both the centers, with and without iridoplasty, are both effective in aborting an acute attack. Apart from that, obviously, you need to do an iridoplasty in a plateau iris. And in lens-induced glaucomas, it may be a very, very important tool for faster IOP drop and greater safety, consistency, and efficacy than meds alone. So the take-home messages are, for high-risk cases, an LPI should be done for PACS. For PAC cases, an LPI should be done followed by medications if required, and an early cataract extraction may be an option. Progression can occur in PACD cases even after an LPI. Look for a diagnosis of plateau iris in case of PACD not responding to an LPI. For non-pupillary block angle closure cases, an LPI plus an iridoplasty can be more effective, and iridoplasty can be used in cases of acute attacks, plateau iris, and lens-induced glaucomas. Thank you. So any questions? It's a hugely controversial topic, especially post-ZAP. So pre-ZAP era and post-ZAP era, very different. So post-ZAP, I mean, a lot of people have said, I think we should not be doing iridoplasty. I've quoted Krishnadas sir's article, also a guest editorial. So I think the message that should go out is you should do a PI. And if possible, go ahead with an iridoplasty. Any questions from anybody?
Because let's say that's a technique that not everybody is comfortable with, and we also know iridoplasty regresses with time.
That's a very good point.
So the thickness of the iris does change,
yes,
and with the forward movement of the lens, again things can change.
Right.
So why not pilocarpine in these eyes with plateau iris?
Right. So, I mean, a lot of people say I have a lot of issues with pilocarpine. I mean, some of the patients, I think it's a wonderful drug, and when it was out of the market, we were like going crazy. So I believe pilocarpine is an extremely, extremely important drug. But as a procedure, somehow, we've accepted PIs, but we've not accepted iridoplasty. I mean, me personally, I haven't done much iridoplasty after leaving Arvind. So maybe it is a very, very important procedure that we kind of have not realized the importance of. Pilocarpine, for sure, it's an extremely good drug. And if you don't have access to iridoplasty, definitely pilocarpine. I mean, you can keep the patient with pilocarpine. There are patients who are there for years. And one more good thing about pilocarpine is it's probably the only drug which has a good effect on the ocular surface. I mean, for the tear production and all, I think it's a good drug to use, really good drug.
So I mean, it's not that, so I have an access to iridoplasty, I still don't do it. I'm comfortable with pilocarpine if the patient is able to tolerate. We just have to convince them that, yes, it stings because of its acidic pH, and the number of times that you need to use also differs based on how much of force you need to use to indent. So sometimes you give it prophylactically once or twice, or sometimes you may have to go up to 4 times based on the need. But the problem with iridoplasty, at least for me, correct me if I'm wrong, is the amount of pigment dispersion that happens, and very, very shallow anterior chamber that you have in the periphery, in the extreme periphery where we need to do on 360 degree.
True.
So to me, as a technique, it's not a very easy thing to do, and the pigment dispersion is something that I'm not happy with.
Right.
Yeah. So you alluded to the paper that we published. You make me feel old when you say way back in 1999, but so that was that was on PSC and PSCG.
Right.
And the iridoplasty results there were at 1 month post-iridoplasty. So that's actually very early, and that's probably the reason that you had 100% opening, and we were treating only 180 degrees.
Yes.
So
that was one.
Again, the feeling that most of us have is that it doesn't last. So why do we want to induce all this pigment dispersion and all that in the short term? If you're so concerned about the angle, use pilocarpine is what I would also do.
Good.
So about the location of the PI?
No, let's not go there. That will opening another controversial topic. But I just will tell you my experience.
Sure.
I found not many plateau iris in my experience. Most of them turned out to be phacomorphic because after doing anterior sagocity. What I found is that exactly the experience Shirisha and Ronnie have. That is, I did pyridoplasty. Then 5 years later, I needed to repeat that. And then again 5 years later, then I said enough. And I started pilocarpine. After that, I have started pilocarpine at night for almost all of these kinds of patients, unless they are high myope. There are some patients who are high myope and have very narrow angles.
Correct.
Those patients, they're at risk for a retinal tear
Retinal
or detachment.
detachment.
Those patients, I might go ahead and do a iridoplasty. But otherwise, I'm using pilocarpine once at night. And they're very happy because now the presbyopia is also treated.
So I would just like to ask Ronnie sir and Shrisha ma'am, like what sir said. I mean, are we missing plateau iris cases, or are these studies quoting an abnormally high value? Because we really don't see so many plateau iris cases. I mean, but the studies indicate that there are a lot of plateau iris around.
No, we do see. We do see.
So it's around 20 to 30%.
Easily, easily.
So that means there is.
Seeing is because we're not looking for it,
Maybe, yeah, yeah,
right? We don't how much how. Yes.
right, right.
For the benefit of all the audience here, so post PI management, if when you said, when you call them back a week later or 2 weeks later, whenever they come back, apart from checking the intraocular pressure, we definitely need to gonio them.
Gonio.
And then under ideal conditions and understand what is happening in the angle. Sometimes it's very nice to see the entire angle is opened up. Sometimes 2 quadrants are opened up, 2 quadrants are still occludable. Sometimes all 4 quadrants are occludable. So we need to gonio them, and then that has to repeat on a regular basis. Call them back. For us, it is a routine that every yearly they definitely undergo a undilated gonioscopy, and then we dilate them as well. So even people who are on pilocarpine, so one of the problems I hear is that you put them on pilocarpine, you have difficulty doing cataract surgery. Forget about it. We do it 10 years later, 20 years later. It just takes a second for you to dilate it. It really doesn't matter. But you do give the benefit of the treatment to the patient. Otherwise, you may be losing the eye, and we see that quite often.